of her knowledge. Thank you.
Thank you, sir. Now, it is my honor to welcome our chief guest for the day, Dr. Rekha Korean, Director, Senior Consultant on Obstetrics and Gynecology, Joseph Nursing Home, to please discuss the current scenarios that are revolving around cesarean deliveries. Yeah, please.
Connect பண்ண முடியுமா? Ma'am, is there a possibility for you to mail this to me, to our ID, so we can use it to us? You can't connect? Yeah, we can connect. Yeah, that would be better that I can handle it. இது இல்லையா? என்ன இருக்கு அது? Zoom எல்லாமே இந்த லேப்ல தான் கனெக்ட் ஆயிருக்கு. Zoom எதுக்கு? இது ப்ரொஜெக்டர் இல்ல கனெக்ட் பண்ணியா? அதுக்கு சும்மாவே இது கனெக்ட் பண்ணிடுறேன். இதுதான் Zoom லிங்க். ஓகே. இல்ல இதுலயே கனெக்ட் பண்ணிட்டோம்னா பிரச்சனை இல்லை. ஆமா அது எடுத்தாங்க. ஆன்லைன் வந்து கேட்க முடியும்ல? யூடியூப்ல ப்ளே போடணுமா? Good afternoon, everybody, and welcome to this session. It's so nice to see as women who want to have their babies interacting with the doctors. I know we doctors sometimes are lacking, that we don't interact so much with you. It's a consultation of 5 or 10 minutes and then you're away. But this sort of a session makes you think, want to ask questions. So basically, my talk is only for you to stimulate you to ask questions to the next talks when the panel discussion is there. So you can ask and get comfortable with your state, how we are going to deliver, what are the things. Of course, we all want to deliver in this beautiful hospital. It's a fantastic place to bring a new baby in, but you will have your doubts. You working or not working? Just on it. Okay, no problem. I think I'm audible, right? Yes. Okay. It's okay. Yeah. So I just thought we'll go through a few things just to make you interested in what's going on. So let's start at the very beginning. A very good place to start, right? I don't know if you all remember the sound of music. Okay. So, the first cesarean was done initially on dying mothers to take the babies. It's a morbid thought, but this was how the first cesarean was done. Obviously, nobody would cut a live person. They would be crazy to do that. But in a dying mother, apparently, it's very, I don't know if it's very clear. It's a little enlarged picture. This is Asclepius being removed from his mother by Apollo, which is why I think Apollo took that name, right? So Apollo is a woman doctor at that time, the person who did the first surgery possibly. So this was because of an order from Emperor Julius Caesar to remove the baby from the dying mother, maybe in a battlefield, maybe somewhere, we do not know. But because of that, the word cesarean came around. Okay. So let's look at how in the animal world babies come out. So this is the whale baby, which is multiple babies inside the whale's stomach in the uterus, and they have decided collectively, we will fight here and somehow get out. And if you see pictures of the delivery, these babies are ejected into the air, and they fall back into the water and immediately start swimming. Okay, so that's their attitude. Now this single baby sitting inside says, I will peck my way out of here. Somehow or the other, I will get out of here by doing some hard work. But what does the human baby say? Push, woman, push. Okay, somehow get out of the mother. So now, we are looking at the animal kingdom. And I would just like, if it's not too gory for you, if anybody is faint, I will off this video. This is a cesarean section being done in cattle, okay? So this you can see, is the skin being cut. So, is that okay, Jayashree? Nobody is worried about.
For us, it's okay.
No, no, but for you all, are you okay with that? Okay. If anybody is feeling uncomfortable, I will switch it off. So this is the skin being cut. They enter the abdomen, and then what you see white there is the uterus or the baby womb. Okay, the baby bag. So now they are controlling some bleeding, which is what we also do with different methods. And what he is using is quite different from what we are using. That's a letter opener. Okay, a big letter opener. With that, it's being cut. Okay, so you can see it's a big animal. Probably given anesthesia, don't worry. The mother is not feeling pain, and you can see the struggle, which is sometimes what we doctors as well have to do. Okay, because babies get sort of stuck inside very badly, and we do have to struggle quite a bit sometimes to get the baby out. So now you can see that the baby is being pulled out. Okay, leg first. Sometimes, as babies do, they come leg out first, and the baby is born. Okay, there it is, taken, put on a cloth, and the baby is almost ready to get up and walk, unlike human babies. Okay, so so this is what it is. Therefore, if you look, even animals these days require C-section. Why? They did not have it earlier. Why does this happen? I think it's because more than every mother and every baby, whether it be animal or human, is very important now. Okay? In those days, they couldn't do anything much, perhaps that's one of the reasons. Or they didn't attempt to do things like this because, okay, everybody knows in childbirth, mother sometimes dies, the baby sometimes dies. That was the days of yesteryear. But now it's no more so. Every mother and baby is important, and we have to save every mother and baby right from the day you're pregnant to the time the baby is born, and the pediatricians will take care after that. So, however, over the years we found, as Dr. Jayashree Gajraj mentioned, the rates of cesarean section have been climbing. We started it with the intent of saving the baby and saving the mother in many situations, but after that, somehow it became an easy way out for mothers. They said, okay, get the baby out safe. So if anything happens to the baby, the first question they ask the obstetrician is, why didn't you do it earlier? You knew there was something called cesarean. Why didn't you do it 2 hours earlier? Why didn't you? So this is the question we get asked. So I think that may have been a reflex, one of the reasons why people started doing more and more cesareans, because the demand came from the patient side. Okay, we want safety. We don't care what it is. We don't care for the money, but we want the safe. Safe baby, of course, can be done by cesarean section. We have problems with it now, though. So we have realized that it's time to bring the cesarean section down. So we all know we need an attempt to reduce the cesarean section rates. We as doctors, in many of our meetings, this would be a topic of a 1 hour session. Different people will talk on it, ideas are brought forward, we try to bring down cesarean section. But we also need help from your side, from the patient side, so that we can actually do much better. So cesarean section rates are high and we somehow want to bring it down. So this is the whole idea that we are working with now for the past maybe 5 to 10 years. Patient side is also demanding it, doctor side is also demanding it. Because we run into problems during cesareans or during repeat cesareans which we don't want to face. So now at our hospital, you can see in 2000, just see the white numbers, nothing more. 2012 it was 26% cesarean. And in 2013, it went up to 27. So that was a red flag for us. We said we've got to do something to reduce the rates. So in 2018, we managed somehow with a great deal of difficulty and concentration. We brought it down to 21, counseling patients, doing what was necessary. In 2019, it did come down to 19, but again, pandemic hit and then it was sort of not so good now. Now it's about 21 to 22%. But still, we try constantly attempt to bring it down. So let's look at who needs awareness. So we spoke a little about history. and we should, what should we know about it, so that you can help in the decision making process, in being aware of what's going on in the world, I mean in the labor room, and what's going on with you. So why should one be aware? Why do you think one should be aware of what's a cesarean, what are the problems, everything? It's because if you take part in the decision making, it makes it comfortable for you, and you understand why this had to be done. Otherwise, you are just lying down there in pain. Doctor comes and says, "Okay, you can have a normal delivery." Then they see something going wrong, and then they say, "Now suddenly it is cesarean." So you are not aware of what's going on, and that makes you confused and upset. Okay, so if you are part of the decision making process, understand what's going on. That makes you comfortable with the decisions that have been taken. And there are a lot of myths and facts. People feel it's an easy way out, and there are a lot of film star groups who try and have deliveries earlier before the final stretch and the abdomen becomes too lax. So lot of people think in different ways. So these, when the film stars do it, then our patients do. I mean, our patients who are here will think, okay, if they can do it, why not me? I want a C-section. Easy way out, just anesthetize me, get the baby out, and that's it. I'm not willing to go through the pain. Okay, so these again are problems. So if you are part of the deal, then we can do better for you. So when should you be aware of all these things? Ideally, you should be aware before you plan a pregnancy. Okay, so that you can come into the best of health and then conceive. Are there any vaccines to be taken, any preventive measures to be taken? So this awareness, many of you here I think are moms going to be, but even before that, people should be aware so that you plan. Now we have a lot of diabetics in our population, obesity is common in our population now. So all these things can be corrected, and when conception occurs, it's good for the baby, good for the outcomes. We all admit that as obstetricians, that can be difficult in this most common surgery, which all of us are very well versed in doing, but there can be problems. And as obstetricians, we have to prepare ourselves to manage these problems so that the mother is safe. And we need to get out of sticky situations. No doctor obviously wants to get into difficulties either during surgery or with the patient or any other problem like that. Which is why we as doctors want to reduce the C-section in first-time mothers. Because if we reduce the section rate in first-time mothers, many of them will have an easy normal delivery in the second time. So the first-time mother is the one that we want to take care of. Now, risks are what none of us like. Okay, they have to be completely avoided if it can be totally avoided, but this is not easily done. So whom are we worried about? The mother or the baby or the obstetrician's risk? Okay, so of course the mother is the most important in all this, or you think it's the baby? What are the new moms, what are the pregnant ladies here saying, mom or the baby, who's more important? The mom, yes. So the mom is more important, baby comes next, and then of course the obstetrician also is part of it. Okay, so we have to think of all this. But in spite of all such ideas and plans, why do we have cesareans? So these are some of the reasons why everything looks okay on the first scan, on the second scan everything looks good, but in the end they say now you're going to have a cesarean section. So there are people who will come and say, doctor said it's going to be normal, everything is okay, and then finally in the last scan now they have said it's going to be cesarean section. So you're upset about it. But the problem is the baby has turned into foot first position. Okay. So if the foot first comes, then the head of course gets stuck and cannot come out. So these are just some of the things which could happen. The baby gets into a crosswise position, which is what you saw in that video which I showed you. The baby was in crosswise position, so that's why they had to do a C-section for that poor animal. Fetal distress. Okay, some babies get upset with the pain and with the prolonged, contraction on the baby. So it's not comfortable for baby. Don't think it's an easy going for baby. It's also a tough job. Okay, something is contracting on the baby and relaxing. So blood supply is little cut off. So baby gets upset. Which is why you have contractions which relax and then the baby can rest a while, and then before the next contraction comes. Okay, so this should happen, but sometimes what happens is the uterus contracts in such a way that the baby cannot tolerate it anymore. So sometimes the baby is so upset, passes little meconium or motion into the water. Now, when motion gets into the water, because we don't understand that the baby is breathing actually within the womb, the baby is breathing water, it's not air. Okay, so that water which contains meconium goes into the lungs that can affect the baby. So it is why which when we rupture the membranes and find that it is brown color in it, we advise you that there is meconium. We can't wait very long. If baby comes out in 1 hour or 2 hours, that's fine. Otherwise, we will have to take her up for cesarean section. So these are things which can happen, which cannot be predicted on the first scan. Okay, everything looks perfect, baby looks good, mom is good, but these things can happen. Some babies are too small and they can't tolerate much of the pain at all. So they again will go into a distress situation faster. Baby is too big. Okay, we all like to be pampered when we are pregnant. Everybody brings sweets for us, fried food, ice creams, etc. Baby becomes big, and then there is difficulty in negotiating a small passage to come out. Mother's pelvis is too small, especially in a short mother. Sometimes this can happen, the baby is too big, cannot come out. High blood pressure in the mother, which is risky for the mother. So here the reason is safety of the mother. Okay, when high blood pressure happens, the only treatment for high blood pressure in pregnancy is quite different from what an other person like 40-year-old has a BP. Then they tell you salt restriction, take these tablets one after the other, all these things. But this BP, the only way out, the baby comes out. The minute the baby comes out, the BP drops. So we can't wait too long and then we go in for a C-section. Or it can be uncontrolled diabetes. When the sugar is very high, it's very risky for baby. So again, this is one of the reasons. And then in a big mother who's obese, we have 40 BMI and 30 BMI, which is difficult sometimes for them to deliver, or very teenage mothers. So these are the reasons why the C-section is required for these sort of situations. Now, is a C-section always planned? As we said now, it's not planned. Okay, so some very obese lady also, we do not plan. We say, give it a try. Okay, we induce pain, give it a try. If the baby gets stuck, then we go in for C-section. So a lot of things we need to understand is, people feel C-section is so common, it's just a minor surgery. It's only half an hour or 1 hour, and then it's in 2 days I can go home. So do a C-section. No, it's a major surgery. So we have to understand that it's a major surgery, although it's being done so commonly, we just cannot go in and do a C-section without reason. So sometimes we have to fight with people. I had one niece of mine, my own niece. I used to talk to her for half an hour, 1 hour sessions, saying you don't need to have a C-section. She listen to every single sentence I said, every single word she will dwell on. At the end of it, she'll say, "But auntie, I want C-section." Okay, this went on about 3 visits, and then I gave it. Okay, so finally she had a C-section. She's happy, of course, but the point is that many times the requests come from the patient, and we are not able to finally turn a few of them around. Most of them we can counsel and turn around, but many we cannot. So there is always difference of opinion between obstetricians and in obstetrics because of the situations, of the problems at that moment. Okay, the availability of a pediatrician, availability of a neonatologist, availability of anesthetist, etc. There could be differences of opinion. So there are people who will being told they want a cesarean, they will go to the next hospital and say, "I want to have a normal delivery." They have said cesarean. Okay, so there can be differences of opinion, and that's up to each patient and the doctor. Okay, so it's good to know difference of opinion between doctors, and it's also good to know what you want. So these days we usually ask the patient to write a birth plan. What are the things you want in labor? Because we are there to help you. We want you to have a comfortable stay, comfortable delivery, comfortable atmosphere to deliver it. So if there are, because lots of what is that? Not WhatsApp, what's the thing? Instagram and Facebook and all that, which I'm not on. So those things will tell you this is the way to do it, that's the way to do it, and a lot of new things. Okay, and a lot of people who want to conduct the deliveries at home. There are husbands who want to conduct their wives' deliveries. This is all very dangerous. Okay, so you need to understand what can be done, what can't be done, what is safe for the mother, what is safe for the baby. Okay, so you all have to tell the pedio obstetrician and the labor ward what is it you want. Okay, do you want to wait a long time? I don't want to wait a long time. Do you want somebody with you during labor? And all these things can be discussed with the obstetrician. So we need to keep all possibilities in mind in different situations. Now I think possibly we can go in for a question and answer session, something with I think Dr. Indra and Maran will be doing. And thank you so much for the patient listening.
Next.
Slide show போடுங்க.
இதில் இருக்கு already.
ரெண்டு கேப்.
ஆமாம். Thank you, Dr. Rekha ma'am, for sharing such a lot of knowledge and your insight about cesarean and the current scenarios that are revolving around it. Now, without any further ado, let's start our panel discussion. I would like to invite Dr. Indra Nedumaran ma'am to be the coordinator in conducting this panel discussion. On the panel, we would like to invite Dr. Lakshmi Ashwathaman ma'am, Senior Consultant Obstetrics and Gynecology, Dr. Pilli Govardhan, Senior Consultant Neonatology and Pediatrician, MGM. Dr. Meenakshi, Senior Consultant Anesthesiology. Dr. Dakshayani, Director, Senior Consultant, Varam IVF.
Good evening, all. I think we had a mind-stimulating session on LSCS by our beloved Dr. Rekha Korean ma'am. So I was thinking first I'll start the question, but now after madam sessions I have changed my plan. I think any of you, if you have any questions, our panel is ready to answer. Any doubts you can ask all. I think expectant mom, we are here having it here. Any questions? Our panel is here to answer your queries.
Ma'am said about high blood pressure. So, what do we have to do to avoid that or to keep that in control?
I think I'll give it to our senior consultant, Dr. Lakshmi Madam, to answer this question.
Actually, this high blood pressure, what we call the preeclampsia or gestational hypertension in pregnancy, is not due to the lifestyle. Though some of them may have pre-existing hypertension, which is continuing into the pregnancy. But the hypertension, specific hypertension, which belongs to pregnancy alone, is called preeclampsia. We can probably screen for it and start off with the echosprin if you turn out to be positive for developing the preeclampsia. There are screening modes now, which is done along with the NT scan. They'll do the uterine Doppler plus some chemical substances which are measured in the mother's blood. So if that risk factor is present, if they find out that you have the risk of developing the preeclampsia, then echosprin can be started to reduce the risk of preeclampsia. It may not completely prevent it, but it will definitely reduce the severity of the preeclampsia. This preeclampsia, the changes which happen in preeclampsia is induced by the pregnancy itself. So actually the treatment for that would be to deliver the baby, if the baby is mature enough.
So I think complications, so you should have a regular antenatal checkup. You make sure you check your blood pressure regularly, take adequate rest, and follow your obstetrician instruction. That is very important. Anyone else? Want to ask question?
Hello, ma'am. Aishwarya. Jaisha, ma'am, thank you. I have delivered my twin babies here with her after consulting. So my question is, in general, there is, I'm not sure if that is a myth or the truth. If the first delivery is a C-section, so there is no possibility of a normal delivery in the second pregnancy. Is that a myth or is
By the
that
double
true?
it's
Can you please
I think
clarify?
I'll ask Dr. Dakshani madam to answer this question. I think first
Is
C-section is.
Hi, Naveen. Aishwarya. It is possible to deliver normally after the first C-section. We have actually conducted lots of normal deliveries after the first C-section. Maybe because here, as ma'am was just explaining, there are different reasons which a C-section has to be planned earlier also, or sometimes it happens during the previous or the first pregnancy. Say if it was a breech presentation and we did not want the mother and the baby to suffer, we would have conducted a C-section at that time. If the next pregnancy was a normal vertex presentation, there are all like we can give you enough time to reach your term and see whether you will go progress into labor. Maybe we might not take risks of inducing too long or waiting too long, but then we will definitely allow you to try and have a normal delivery.
So is there a time that is required between the first delivery and the second delivery to go with
Mm,
the normal one?
I can continue. I think it would be safe if it is more than 2 years and above. But look, there are pregnancies which are like couples who suddenly have a second pregnancy within a year's time, probably planned, sometimes in elderly couple or sometimes in young couples also because they did not plan but they would want to continue. In such cases, if they're coming in a very short period, maybe we should be a little more observant about the pregnancy when it comes to the third trimester.
Thank you, ma'am.
I think thank you. I think you got the answer. I think if you have after 2 years, and if your baby should be ideal body weight and you should not have any risk factors, then we can give a try. But we don't go for induction of labor. Am I right, ma'am? Yeah. The inducer, okay.
Yeah, we do induce, but we don't wait very long. So then what we do is we use methods which will not cause the main problem in a woman who's had previous cesarean is that there is a scar. Okay, so obviously the previous scar is there, and as contractions, no, as in contractions come, then you don't want that scar to have a problem. Okay, so remember, you can have a normal delivery after C-section, but it's not totally safe. You can't be bindas about it. Okay, we have to be acutely aware of this patient who is in labor. In a normally laboring first time mother, we won't be as tensed about it. But in a previous cesarean who is getting into labor, we are also tensed. Our heart rates are also going up. Okay, remember, we are taking care more of the mother. We are watching the mother and the baby's heart rate often because we don't want to have problems. So at the very outset, we will advise the mother that yes, you can have, but these are the risks. Okay, risks to the mother, risks to the baby. Although it's very low, less than 1%, we have to bring it out and you have to know about it. It shouldn't be that I didn't know, you said everything was okay and now something has happened. So it could happen, and therefore what we do is we watch the baby and the mother much more frequently. We do what is called continuous CTG monitoring, that is contractions and the baby's heartbeat are looked at continuously. So it's a bit uncomfortable because you're lying down to monitor the baby's heartbeat. You cannot move around as much as otherwise. So all these conditions are there, and we will discuss this with the patient. And if you are fully willing, you will take it. Another one will say, no, no risk to the baby. I don't want to take this. You just do a cesarean section for me. So if you are willing to take that 1%, or actually it's 0.5% risk, then we are okay. And we do induce. We use methods which will not cause contractions. We put in what's called a little bulb, sort of a little balloon into the mouth of the uterus, stretch it. So once we start stretching it, then sometimes the patient will get into contractions herself. So it's not external medication causing contractions, which will be stronger contractions, which can then cause a problem to the previous scar. Okay, so we watch you carefully. We will have the anesthetist with us or continuously within the hospital or within the labor room. The pediatrician also will be continuously, because even in that 0.5% chance, we want safety. So we will make sure we are all around when such a patient is in labor.
I think this brings a question to Dr. Meenakshi. I think how to select a hospital. Suppose no expectant mom is there, so she wants to have a safe delivery. So what is the criteria? I think anesthetist will be the best person to answer that.
Right. So, to select a hospital for a delivery, for a safe delivery to both the mother and baby, the main thing is you have to see the labor suite, whether it has all the monitors, CTG, as ma'am said, continuous monitoring, and heart rate and blood pressure monitoring. Everything should be available. And more importantly, the doctors, both obstetrician, anesthesiologist, as well as pediatrician, all three of them should be available 24 into 7, so to provide services at any time in case of emergency. And then a blood bank, functioning blood bank for all blood groups should be there, because there is a risk of bleeding for any obstetric patient at any time. So functioning blood bank should be in the hospital itself. If all these are there, then it's a very good setup for safe delivery. NICU, yeah.
Thank you. So, any other questions from the audience?
Yeah, good afternoon, ma'am. So I was diagnosed with two fibroids, one large and one small. So I was told a cesarean is very compulsory in this case, and maybe the fibroids could be removed at the time of surgery. So I'd like to clarify both whether it is compulsory that it is cesarean, and will the fibroids be removed at the same time?
I think Dr. Lakshmi Madam will answer that question. So, yeah.
Whether it's going to be an operative delivery, like cesarean section or vaginal delivery, will depend on the location of the fibroid. Not all those fibroids need a cesarean section. Suppose they are in the top of the uterus or the side walls, they don't need a cesarean section. We can deliver them normally. The size of, if the fibroid is very big, it might cause a little obstruction, but that we will know only when the patient gets into labor and progresses in labor. But whether the fibroid can, I mean, cesarean section being done to remove the fibroid during the cesarean section is not a good advice, especially the pedunculated fibroids may be the fibroids with the stalk, with the, that can be removed during the cesarean section, but not a fibroid which is well embedded into the wall of the uterus. So the blood supply during the late stages of pregnancy will be around 600 ml per minute. So to do a myomectomy or removal of the fibroid might cause a lot of bleeding. Normally, that was the teaching all this time, but now newer guidelines have come that we may attempt it taking a lot of precautions. But it's generally not advisable to do a cesarean section only to remove the fibroids. That cannot be the indication.
I think you would have understood that fibroid is not an indication for cesarean section, but if it comes on its way for a vaginal delivery, you may need a LSCS. Okay, I think that is the answer for it. And any other questions from the audience? This side, no questions, sir. Okay. I think if you people are not asking questions, then I'll start asking questions because I have so many.
Hello everyone. So actually, my wife is currently 5th month pregnant. So if we are planning for, I mean, we cannot plan it. Just planning for normal delivery. So what are the steps or things that we can do to help us and help you all to make it a normal delivery?
I think this question I want Jayashree Madam to answer. So. No. I will let everybody get involved also.
I think it's an excellent question, and I'm happy planning for it. It's very good. First and foremost, a very positive attitude. You should be convinced that you want a normal delivery. Like we currently have a dad who actually not sure, but he just keeps saying, "I want normal delivery," not for him but for his wife. Okay, so it's easy to say I want a normal delivery, but the mom, her wishes we have to respect. If that's what she wants, then we start preparing for it. As Dr. Rekha said, we have this birth plan in the beginning. So we ask you roughly, what do you want to do? What are your ideas? Do you want pain relief in labor? There are a lot of questions that you need to answer, and then we plan out how you will go about it. So through labor itself, an extremely positive attitude. There could be small problem, but then we help you to overcome those problems. Doing all your antenatal checkups correctly, going for your blood pressure measurement, scan, etc. Making sure that you're on track. And then the labor itself, preparing earlier, as in attending prenatal classes, which prepare you for breathing exercises, how to relax in labor, and pain relief in labor. See, there's no point when you're in labor asking you, do you want pain relief? Do you want injection? You should know enough about it before you get into labor. And when I say you, it's always the two of you, because it should be a unit. Okay? And you both should be in sync. So that's how you have to take it forward. And if you do that, I mean, there's absolutely no reason, unless we have clear indications for cesarean, every mom should go through a trial. And if for some reason, as Dr. Rekha said, the baby is not happy, mom is having some issues, then we go for a section. So elective cesarean section is indicated in very, very few situations. So yeah, you can certainly prepare yourself. Sure. You should.
I think first itself he told what steps you should take. You need to walk more. More steps will help you actually. Yes.
I'm happy about your question because it was the husband asking for you, and both of you are really planning. Because I see the opposite happening in many families. The whole family is actually bringing the patient, carrying them inside our chambers. They're not even allowing them to walk in properly. Like they're all, so protective about them. And the same is happening back home also. They're not doing their normal work. They're not even doing their household chores. And when it comes to the third trimester, everyone has a question: how do I go for a normal delivery? And I sometimes feel like even smiling at them when they came. Their due date is on 29th of this month, and today I will have a question what exercise I can do. Okay, so that is something different.
One more question, ma'am. I think that leads to it. I think to Dr. Vanita, madam. Actually, a couple is planning to get pregnant. What are the steps they should take to have a normal delivery in future? Anything is there? Any pre-pregnancy counseling helps?
The first thing is their BMI. They have to look into their weight. They have to do exercise. As a pre-pregnancy counseling, we do two things. One is we check their basic health levels. Like we have to look their hemoglobin, sugars, thyroid, all that we do. And then we have to check her weight and BMI. If she's little on the higher side, we have to counsel them about the lifestyle modification to reduce their weight, then plan for pregnancy. So if they go through all this and with everything perfectly normal, then I think it's easy for them to have a normal delivery. Then they can, instead of becoming pregnant and then trying to do all these things, I think we have a pre-pregnancy counseling session, take care of all these things. Then once they become pregnant, it's more easier for them to go for a normal vaginal delivery.
Thank you, ma'am. I think Dr. Rekha madam in her slide she was putting what are the indication for cesarean section. I think important was like big baby and gestational diabetes and diabetes. So actually going for a pre-pregnancy counseling helps you to reduce the risk factor during pregnancy. You learn it better. So always pre-pregnancy counseling help you to reduce your risk factors. You have to understand that obstetrician role in taking care of pregnant mother, we can't reduce your risk. We can identify. You have to take care of yourself to reduce your risk. Again, taking care of pregnancy, we can identify the complication early and treat. Sometimes we can't, obstetrician can't prevent complications. I think that all pregnant mothers understand. Any other questions?
I have a follow-up question. Sorry. Um,
why it's like some hospital or some patient are asked to get admitted on their due date? Why can't they wait until they naturally get into labor? Why are some why this illusion happens?
Okay.
Or what can I do to avoid this medical illusion?
I think this question I'll ask our Dr. Lakshmi Madam to answer. Yeah.
Actually, according to the guidelines, we can wait for at least 10 days. UK allows it for 10 days, and USA allows it to be delayed up to 2 weeks also. But then there the patients are very compliant. They come back every alternate days or twice or thrice a week to check on the baby. Now the placenta is aging. So the blood supply to the baby may not be as effective as in the beginning of the pregnancy. So we have to monitor the baby very, very carefully. And if there's any indication, we have to deliver the baby immediately. So that follow-up is very necessary. The awareness in the patient has to be very necessary. So if that compliance is not available, then we don't take the risk. We admit, not that you should deliver at 40 weeks. Waiting up to 41 weeks plus 3 days or 42 weeks is okay, provided you are ready to come on alternate days or twice a week as necessary according to the patient to check on the baby. But if there are any medical complications like diabetes or hypertension or even a twin gestation, we don't allow them to go postnatal. There are specific indications. But a normal pregnancy can wait, but under monitoring. That is very underlined twice.
How about VBAC, ma'am? For VBAC also you wait for the same amount of time until term?
The same thing. We don't have to wait, I mean, do the induction of labor earlier. The more we wait, provided the conditions for the baby is okay, it's better. The more chances of having a natural labor is much more.
I think when you are going through your antenatal care plan with your obstetrician, believe your obstetrician, listen to her, so she may be knowing better. So you allow your obstetrician to take a decision. You can always discuss. I think before admission, you have all the opportunity to have a counseling with her, discussion with her. So based on that, he take a decision together. So not you alone. So because so caregiver as well as like a caretaker, both are involved in that. So I think it is a combined decisions will be taken. It is individualized. We can't treat it as a whole for everyone. It is not the same. Any other question?
Hi, ma'am.
Yeah.
I'm a first-time mom. I'm consulting Jayshree, ma'am. So I got a question. Like, there are so many videos in Instagram and YouTube. So there they say from the starting from so and so week, you need to do these stretches, yoga. So they say when you do it, it will increase the chance of vaginal birth.
Delivery.
So
Okay.
I wanted to know whether will that increase the chance
So
of
whether it is fortunate or unfortunate, obstetrician doesn't have time to see all those videos. But anyway, regarding the exercise, I'll ask Jayshree Madam to answer the queries.
What equipment are you referring to? So, no, I think, see, everything has a plus and minus. Definitely, some of the videos that come out, the information that comes out on Insta or Facebook, etc., it is good. But you should take the right things. And I think where you have a doubt, you can talk to your obstetrician and check. Because as she said, we don't have time not to see that, but we don't have time to even talk to you all properly, which is sad. We should actually be spending more time. But because of lack of time, we don't talk to you enough. And parallel, I think you all develop a certain your own ideas, and sometimes there is no sync between us. But certainly, there is no hard and fast rule about anything. Stretches, everything helps, but under supervision, you should do anything. Just don't look at a video on the net and then start doing it yourself. And that is why well conducted prenatal classes help. It could be yoga, it could be a instructor doing just lamas exercises, anything. But it should be under supervision. And it's usually a physiotherapist who's trained in this. There are special courses which people take. And these people will know what is wrong, what they should not do. They'll be able to give you the right guidance. So please don't blindly follow what is on the net.
I think before starting any exercises, feel free to discuss with your obstetrician whether he can do the exercise, any contraindication is there. and we can discuss the type of exercise. Maybe you can bring a picture or something, so you can check it with them whether you can do the type of stretches, whether you can do the type of exercise. You can always feel free to discuss with them. I think that will help. And I think from now onwards, here, I think the aim of this program is we want to have it as a continuing program where we empower a pregnant mother and their family to learn about pregnancy, learn about labor, and learn about exercise. I think we'll continue from now onwards. I hope HOD madam accepts that. Any other questions?
One more question, ma'am. Actually, the question is from my mom.
Yeah.
She wanted to know, like, when there are false people start, people say. So when actually when we get to know the actual pain comes in, because one of my friend also, like, they say, I went to the doctor, that was my due date, but I didn't get my baby. They asked me to go 2 more days. So that was a false pain. Something they were telling me.
Okay, one thing is don't learn from friends. Anything you discuss with your obstetrician. Sometimes you get a lot of wrong information. I think this question I'll ask Dr. Rekha madam to answer. Yeah.
So what did you say, your friend?
Some false pain she.
So to find out, okay, if you're near term and you have pains, it's very difficult for you to decide, okay, it's the pain here, it's the pain on my side, it's the pain on my thigh, that is false pain, this is not true pain. It's very difficult for you to decide. For us also, when we see you, we have to feel the abdomen, see the contractions. Are they increasing in intensity? Are they increasing in duration? So there are a lot of little things which we look at, and whether the head is getting fixed. Okay, and also we need to see at that time the baby's heartbeat. So, unfortunately, even if you're on the phone directly with Dr. Jayashree, she will not be able to actually tell you is it false pain or real pain based on what you're describing it as. So, you need to get yourself into a hospital, check up. If they say false pain, go home. I know it's very difficult. Suppose you're coming from very far, then it's a bit difficult. But safety for the baby, because even during this false pain, sometimes baby can have heart rate changes, which then will be not checked properly if somebody just tells you on the phone. So it's difficult to differentiate. I would say you have to come in. And about exercises, as she was mentioning, don't do unguided and your own exercises, because sometimes it depends on your level of enthusiasm. You overdo it, and there is something called duck walk, which I don't know what exactly it is, but somebody does duck walk, and this duck walk has created problem. Why one lady finally came in and said, I have stretched the groin muscles, I cannot lie down on the labor board, you do C-section for me. So overdoing things without guidance sometimes can cause more problems than helps. Sometimes these exercises are good because sometimes we do not stretch our bodies in the right way. So yoga under guidance, or as Lame's classes under guidance, will always help. So this butterfly exercises are there. So all the animals are there in it. So yeah, what pose? Cow pose. Okay, yeah, exactly. So these are there, and people want to deliver on the floor. So a lot of the demands are coming because of YouTube. And as older obstetricians, maybe the younger ones will be okay, but the older obstetricians, we find it difficult to deliver a patient on the floor. I mean, this is really difficult situations for us. And people want to deliver in the water. Again, that's very risky for the baby, because we got to fish the baby out correctly. Am I right? And then there can be risks. Okay, so there are people who want to look at YouTube from abroad, from somewhere. Okay, they are doing it in that place, this place, but risks are involved in many of these things. And as you asked, when we wait more and more after term, okay, the word term or finishing of 40 weeks is for a reason, because at that time, if you deliver, the risks to the unborn baby or to the newborn neonate is much less. As days goes on, sometimes, as she said, the placenta is getting old. The placenta is not, why we stop having babies after, why can't we go on for 15 months? Because the placenta stops supplying blood to the baby at a particular time. Now, it's different for you, it's different for another person, it's different. So we are also not able to say, okay, you are the one who will stop supplying baby with blood at 38 weeks or 39 weeks or 40 weeks. So beyond 40, we are also a little bit jittery. So come in for more frequent checkups. And also there is a little racial difference. In Sweden, for example, they wait fully up to 42 weeks. But in Indian population, not that much. Okay, we wait 40 plus 2, 40 plus 3, not more. Or we call them in for a scan to see if the blood flow, we do Doppler studies to see if the blood flow to the baby is okay. So these sort of things actually can help to find out if the placenta is beginning to give up. Okay, so there are some placenta which will give up at 38 weeks also. So we need to watch out. That's why during end of the 40 weeks, we are watching you a little more carefully, asking you about movements very often. So which is why 40 weeks has been set from a long time ago. Okay, even before allopathy came in, women knew this is the time. Okay, 10 months, they count 10 months and they tell you, okay, you should have delivered by now.
I think the lighter vein about false pain, if I can just add, there is this common practice in our families. They will give them rasam sadam and wait and see whether the pain goes away or not. Please don't do that. I'm sure Dr. Meenakshi will agree with me. If you're coming to the hospital, please don't eat at night. Carry the rasam sadam with you if you want. Come here, have a checkup, make sure that you're not in labor, and then eat the rasam sadam. Okay, it should not be a rasam sadam test to find out whether you're in labor.
I think false labor pain, even sometime when we are seeing for the first time, we may not be able to identify. Sometimes you may be having contractions. We need to observe you for maybe 4 hours to 6 hours. If you are not progressing, that means you are in false labor. If you deliver, you had a labor pain. So sometimes we come to a conclusion like that.
You need a cesarean for some reason. As soon as you come in, the worst scenario is for the tummy to be full. Okay. So I'm sure Dr. Meenakshi will be able to tell us a little more about that.
Okay.
Prepared for it.
I think like on the what do you expect when pregnant mothers come to the hospital? Suppose if you need to take her to theater, so what is the prerequisites?
First, as Anne said, you should try to come in an empty stomach or at least clear fluids like water, coconut water, clear soup, something like that you can have lightly and come, because we need 6 to 8 hours of fasting before taking up for a cesarean section. If any emergency arises, then you have to be in fasting. Otherwise, there is a risk of aspiration, that is, the food contents may pass into the lungs and cause complications. So it is better to avoid eating until your obstetrician confirms that you're okay to go ahead and eat. So even during labor, it's better to be on clear fluids so that anytime any emergency can arise, so we can easily take up for cesarean section without that risk of aspiration. So
milk is also another offender.
Yeah, milk, tea, coffee, for all these fluids, even juice, we have to wait for 6 hours. So it's better to have coconut water or plain water. Yeah.
Okay, thank you, Dr. Meenakshi, madam. Now, other question is when mothers should visit you, like no, when they are planning for a birth, when you want to meet them actually, which trimester? So what will be you'll be discussing with them?
So ideally, all pregnant mothers, we expect to come and meet us around 36 weeks of gestation, around term. So that we can assess you completely. Like, we'll get a full medical history from you. So if you have any other medical conditions, hypertension, diabetes, some patients may even have cardiac problems or asthma. If any uncontrolled problem is there, we have time to optimize. Or all these, if any high risk is there, we expect them to come at the beginning of the trimester, that is around 28 to 32 weeks, so that we'll have adequate time to optimize whatever medical condition is there. We'll obtain full medical history and examine you and order blood test, echo if needed, and all those tests we can investigate and optimize all the medical conditions, so that you'll be fully prepared for your delivery process. And also we can discuss the plan of anesthesia if you're going in for elective cesarean section, or if you're going in for labor, we can discuss the methods for pain relief during labor. So for both of these, we can fully evaluate and give you the full details and explain the risks and benefits of each method, so that you will be well informed before coming for the delivery process.
Painless labor.
That's what, ma'am. Pain relief. So for painless labor, we have, and the gold standard, that is the most safest and effective method, is we have epidural anesthesia. So we have 24 into 7 anesthesia on call here. So when the obstetrician gives a go ahead, we can go for an epidural. So we'll give an injection in the back and place a continuous catheter, and we'll give local anesthetic to produce numbness below your waist. So the medicine will be going continuously through the labor process. Throughout the labor, you will be having adequate pain relief. That is the gold standard now for all deliveries. We can do it.
Actually, we always have a doubt whether we stop the pain or they won't feel. Because every time when you tell pain, they'll be asking whether you are stopping the labor pain.
Yeah.
Everybody asks a common question.
No, this is only a sensory block. So you will not have pain, but the uterine contractions will not be blocked. And it will definitely not prolong the labor process. There are numerous studies which have shown the labor process will not be prolonged, and there is no increased incidence of cesarean section after an epidural.
One more question to you, madam. Actually, so like always, the thing is, no, like they would have had 20 years back some delivery with the spinal anesthesia or some procedure. We always think because of anesthesia, I'm having back pain. So, what is your opinion on that?
Yes, ma'am. Actually, a lot of patients, when we explain about spine, yeah, a lot of mothers as well as other patients who come for spinal, they ask the same question that 20 years back we had cesarean and still the back pain is there. But that is a myth actually. Whatever trauma we produce during an injection, it should settle within a week. This back pain is not definitely because of an epidural or spinal. Definitely, like in any pregnancy after delivery, a little bit of weight gain will be there, and during pregnancy the back curvature, the lordosis of spine will be increased, and also the ligaments and joints will be lax because of the hormones produced during pregnancy. The joint laxity is the one which helps you in delivering the baby through vaginal delivery. So this joint laxity and increased weight gain, all these factors contribute to the back pain after delivery. So to decrease the incidence of back pain, what we have to do is postnatal exercises. Those things will definitely, and reducing weight, all these things definitely will help to reduce the back pain, but definitely not because of the spinal. There are numerous evidences.
Actually, I think what madam says is correct. I think postnatally, when we have back pain, the reasons are like we are not used to carry anything. So every time 3 kg baby will be keeping on carrying 20 minutes, 30 minutes. So when your muscles are not good, especially your shoulder muscles and upper back, if it is not strong, definitely you'll get a upper backache, neck pain. Again, low backache is quite common because of your posture. So actually, breastfeeding techniques are very, very, you have to have a good posture. You have to maintain a good posture. Otherwise, you develop your upper back pain and lower back pain. How to overcome that? You have to start strengthening your muscles prior to planning pregnancy. You have to continue throughout pregnancy and do it postnatally also. That really helps you to keep you fit and go through your life in a smoother way. And I think without a pediatrician, the delivery is not complete. Neonatologist. I think I have few questions for Dr. Govardhan sir. Sir is eagerly waiting. So the first question is when to start breastfeeding after LSCS? Like always, you'll be worried. So
Yeah, after cesarean, most of the recommendation they're saying early initiation of breastfeeding is the best. Within even cesarean, we recommend within 1 hour of birth. Immediately after birth, we recommend that always keep the baby in prone position in mother's abdomen and give skin to skin contact, and you can initiate breastfeeding immediately. That is the recommendation. Even baby is in mother is in OT or a recovery room, and no need to separate baby and mother, and always keep baby and mother together. If baby is well, baby should cry at birth and well, then we can keep the baby and mother together and initiate breastfeeding as earliest as possible. That is the best way. And even early initiation of breastfeeding and give colostrum at birth, it will give a lot of benefits for baby's health. That is the recommendation.
and I think always lot of discussion regarding baby's health, whether the vaginal birth is good or cesarean is good for the baby. I think can you tell the benefits for the baby, who is going through the normal vaginal births? Any health, any benefit is there for the baby?
Mainly in vaginal no, births, those babies, this respiratory function will be better than cesarean section. Why it happens? Because when baby passes through birth canal, they have fluid in the lungs. It will be squeezing, so that baby won't develop the fast breathing. We'll call as a transient tachypnea of newborn. All those things is less in vaginal birth. And one more thing is main thing when baby is passing through birth canal, they can expose to good bacteria. It can improve the gut function, and then it will improve the immunity. And one more thing in vaginal birth, the most benefit is early initiation of breastfeeding. Mother will be more comfortable and vaginal birth, and she can have normal diet, and she can have good position and latching, so that it will be easy for mother to handle the baby. And even we can know this, I have seen some babies compared to vaginal birth and cesarean section. Vaginal birth mostly they have less dehydration and less jaundice, because this feeding will be better than cesarean mother, because they always complaining of pain and giving feeding. There is so many complaints. That's why lot of benefits in vaginal birth is compared to cesarean section.
How LCS benefits the baby, sir?
Yeah, some benefits in LSS also. When this baby is larger baby, like there is it's a condition where they cannot do the vaginal birth. In like large baby, we can prevent the birth trauma, like shoulder dystocia, will cause shoulder injury, and other conditions like we'll call as a large head in hydrocephalus, we'll call in those conditions, and meningomyocele, any birth defects. And one more thing is breech presentation. In these conditions, it's always better to go for the cesarean section. It will help the
Thank you so much. And I think I think we handle, I think as a unit, as a Varam, we handle a lot of high risk pregnancies, and we have our IVF unit. I think one question to Dr. Dakshani, madam. All IVF babies, whether we need to go for a C-section or a normal delivery can be tried, ma'am. What is your opinion on that?
It's not mandatory that we should have or plan for a C-section for all our IVF conceptions, because most of them can be given enough time, especially if they're singleton pregnancies. We can even allow them up till about 38 weeks, see what they progress as. For example, if they don't have any medical problems like PIH or preeclampsia of pregnancy, and not a diabetic mother, well controlled, or even if it is borderline well controlled, then we can give them enough time to reach up till 38 weeks plus, during which we will usually assess, because IVF pregnancies also is a hard way the couple would have got the baby. Like they could be very, maternal age might be very advanced. So if she is say close to 40 and after 10 years she's going to have a baby, I'll have to value those things also. So we'll have to see by 38 weeks if it's a singleton pregnancy and her fluids are level, the baby's position is fine, all those things I can still wait a little longer. But then if it is twin pregnancy and there are other reasons like PIH, PET, where the fluids are started to reduce, and there was one or two false pains, and the had babies coming with tachycardia and such things, I think I would sit with them and discuss about a planned C-section also.
I think, thank you, ma'am. I think as we know, all the IVF pregnancies, when they come itself, they come with the risk factors. I think as Rekha madam told, when there is a high risk there are a lot, like more chance of them going for a cesarean section. And we can conclude the session now, or you want? Yeah. I think any other questions? I think this side nobody is asking questions, ma'am. No questions? Okay, ma'am, I think I want to ask question to Dr. Lakshmi, madam. Yeah, yes, ma'am.
Look, we are talking about, I do agree when ma'am told us that the percentage of C-sections have increased. We all should agree, like what was the maternal mortality rate and the neonatal mortality rate about 15 years back has come down by less than 50% now, because globally, even in 2022, about 6.5 billion babies have died globally. This is so that means to say about 6,000 babies around across the globe is not able to do it in their first month, that is the first 28 days neonatal mortality rate. So when it is such things, as ma'am told earlier, the mother is the prime importance we have to give to her health, and then the baby, of course, whether it is twins or a singleton pregnancy, we have to give. So looking into these data, like which is coming up from the UNICEF data or the maternal mortality data, cesarean has been very helpful in most couple also to deliver their babies safely, and the babies to do it well after delivery also. Here we have Dr. Govardhan, who has taken care of my 24-weeker also, who's gone home very healthy. So that is something which we have to appreciate. And it was an emergency C-section. I mean, it hysterotomy. We call it hysterotomy because it is only 24 weeks.
Thank you, ma'am. Thank you for your inputs. Ma'am, I think to conclude, what message you want to give, ma'am, Dr. Lakshmi, ma'am? I think each one can give a one to conclude the session.
It's a good news that they have, the patients have even come to get more awareness. This is what we want, we expect from you, to be more aware to what to expect pre-operatively. The pregnant mothers have a lot of fear, including the family, for her life and all that. So the awareness is very important. What's going to happen before the surgery or before the delivery, and what to do after delivery. That awareness has to come. And uh, googling is not a crime. You can do it, but then get the explanation from your obstetricians. The awareness is the bottom line for everything, for a happy delivery.
Yeah, I think mutual, mutual understanding, it is very important to go through the labor process, and trust. That is very important. I think, sir, you want to conclude anything, so you can share your message.
Yeah. Yes, the cesarean or vaginal delivery, I always recommend be positive about the breastfeeding. And day one, no mother will get the milk. That is the complaint when we goes to see the baby. Mother says, "I don't get milk." No, this almost day five only you get the milk. Initially, you get colostrum. If the baby is latching is good, position is good, and baby is feeding well, active, passing urine, nothing to worry. Nothing to worry about the secretion. Okay, always be positive about the breastfeeding. Always stick with it. Don't go for any other formula or any other alternative. Just always stick with the breastfeeding. That is good for baby and your health also. That is the my advice.
So regarding, yeah, I've already said that. So cesarean is one of the safest method now to deliver a baby, and spinal anesthesia is the safest and effective method for cesarean section rather than general anesthesia, and definitely it will not produce back pain. So that's the.
I think, thank you, Dr. Meenakshi, ma'am. I think the aim of this program is actually, what is Cesarean Awareness Month? To make people aware about cesarean section. So when we do, why we do, where we do, and what are the methods to reduce the C-section rate. So that also you need to learn. I think we can. I think Dr. Dakshani ma'am concluded already, so I'll give it to Dr. Rekha madam. So you want to pass on any message, ma'am? Final message.
It's just to say that the more you interact with your obstetrician and their team, it's not just one person taking care of you, it's the nurses, it's sometimes a team of doctors. So if you get to know them, it's just like going to a new place. You enter into a new place, everybody is new, you're a bit apprehensive. These apprehensions will be allayed if you meet the people, meet the team, see the labor ward, etc. It helps you. Okay, so I can't say that we have been the best of people in helping y'all see the labor ward and all, but we do have sessions where patients can go and see the labor ward. All this actually takes off a lot of tension of your mind. Okay, I always tell you, don't be scared, because if you see, when you sit in a car or a bus and you see all those women walking on the road, remember, all of them have delivered. So just think, why can't I deliver? Where is the fear from? Okay, they can all have babies. I am better than them. So if you think of it that way, and then the doctors, as doctors, anesthetists, etc., will help you through the fear. Okay, there are women who are, even when they see the needle, they are running. Why do we need vaccinations in pregnancy? They ask. Why do we want a TT injection in pregnancy? Because they're scared of the needle. So to that extent, some women are scared. So the more you meet people and the people who are going to be involved in your care, you will be much more comfortable. So which is why these sessions here will help you to interact with people, ask your questions, and be prepared for what is to come.
I think as what Madam says, that for you it is one pregnancy, obstetrician will be going through so many pregnancies simultaneously and so many deliveries. So every time go through that. So like I think no, like the environment may not be very good when you are talking. So actually, when you are coming for a checkup, how to make your things effective, always have a paper in your file or stick it. Write your questions. What are the things you want to ask? When you go home, you'll be having so many doubts. But when you come and sit in front of the doctor, you may not remember anything. Always you prepare your questions. Don't ask immediately after you enter. First you finish everything. Once the doctor advice given, then you start, ma'am, can I have few minutes of a time? Because I have some queries to ask. So they won't say no, they won't send you out. Definitely they'll listen to you. So you ask your questions, get all your doubts clarified and go. And ask them whether no, suppose if I have any doubt, how to approach. So we have a CUG number. You can always send a message or something. So like no, if something is emergency, you can always contact that CUG number and come for an emergency situation. So always note it down. So you should be prepared to get all your answers. It won't come spontaneously. So I think you should be prepared well. And I think to conclude that, in American Journal of Obstetrics and Gynecology, so an article published, effect of physical activity during pregnancy and mode of delivery. Next slide, please. So it is actually a systematic review and meta-analysis using the following data source: Medline and the Cochrane Library. They have studied the randomized control trials. They have evaluated and they found out that, to conclude, next slide, please. So, structured physical exercise during pregnancy reduces the risk of cesarean delivery. This is an important finding to convince women to be active during their pregnancy and should lead the physician to recommend physical exercise to pregnant women when this is not contraindicated. This is not, that is very important. So, always when you are coming for your first visit, your obstetrician would have stratified your risk factors. Ask whether these risks, can I do walking, can I do exercise. So feel free to discuss. So physical activity is an important key to have a safe motherhood and have a healthy baby and have a good postpartum period. Thank you so much. I think with this I conclude.
Uh, Thank you so much. That was a very insightful panel discussion from our anesthesiology, obstetrics, gynecology, pediatricians, and neonatology, and of course, IVF. So, a lot of doctors have taken out their time today and come out to answer all your queries and your awareness, for your awareness. And a lot of patients or to be moms have come here and have been patiently, listening to our awareness program. So, thank you once again. I would like to invite Dr. Rekha Korean ma'am onto the stage and felicitate her with a small memento. I would like to ask Dr. Jayashree Gajraj ma'am to please present a memento. Thank you so much for taking out the time today and coming and sharing your insight with us, ma'am. Thank you once again for joining us today. We look forward to continuing this kind of awareness program and this kind of events in the future as well. Now, I would request every of us to please assemble in the atrium for a group photo and join us for a small high tea that is arranged. Please. Thank you.